Welcome back. It's my pleasure to introduce our next speaker. Dr. Deepak D'Souza is one of the foremost experts on cannabis, psychosis, and early psychosis. He is a staff psychiatrist at the VA Connecticut healthcare system, and he's also a professor of psychiatry at Yale University in Connecticut.
So thank you for inviting me to this symposium. I am going to spend the next 75 minutes or so talking about this, the relationship or the relationships between cannabis, cannabinoids, and psychosis. Before that, I want to just disclose my my funding. Let's see if I can. Doesn't seem like my. Oh yeah, okay. So I'm funded through a number of National Institute of Health institutes, including NIDA, the National Institute on Drug Abuse. I'm also doing a couple of clinical trials with industry sponsors like Takeda. I'm also doing some work that's funded by a number of foundations looking at psychedelic drugs as potential treatments. I serve as a consultant for Abide Pharmaceuticals and Jazz Pharma. But relevant to this presentation, I'm not paid by any producers of cannabis or any opponents of legalization. So just to give you an outline of the talk today, I'm going to talk about the changing landscape of cannabis and cannabinoids, then briefly review the endocannabinoid system to provide you a background as we review the exocannabinoid hypothesis. And then very briefly, I will touch upon the endocannabinoid hypothesis. So every month that I make this slide, it seems like it's old because every month, a couple of months, some state is either legalizing cannabis for recreational purposes or medical purposes. So it's pretty, it's possible that this slide may already be old. But the point here is that the landscape is changing, that many states have legalized medical marijuana. A number of states are legalizing recreational marijuana. And furthermore, many other states are following suit. So what else has changed beyond the legalization of marijuana is that, and I'll get to that, is that while many states still are legalizing marijuana, in the eyes of the federal government, marijuana and its constituent cannabinoids, most of them at least, are considered Schedule 1, or they are banned for any clinical purpose. And what I mean by Schedule 1 is that the DEA defines Schedule 1 drugs as drugs, substances, or chemicals with no currently accepted medical use and with a high potential for abuse. So other examples of this include LSD, MDMA, DMT, etc. So what else has changed is that the THC content of marijuana or cannabis has increased over the last 3 or 4 decades. So in the mid-1995, the average THC content of cannabis was about 4%, and that's increased over the last few decades to now nearly 17%. So the latest numbers from about 3 years ago are that the average THC content of cannabis is now 17%. So why is that important for us to keep in mind? It's important for us to keep in mind because the cannabis that people used back in the 60s and 70s is different from the cannabis now, and therefore studies that were done in the 60s and 70s may not necessarily extrapolate to the current situation where cannabis is much more potent. In addition to THC, the THC content of cannabis increasing, the CBD content of cannabis has decreased, and CBD, or cannabidiol, is another important constituent of cannabis. But unlike THC, which produces most of cannabis's intoxicating effects or the high or the psychoactive effects, CBD does not produce intoxicating effects. In fact, in some studies, and perhaps we might get a chance to talk about this, in some studies, CBD has been shown to have anxiolytic effects and even antipsychotic effects. So the implications of lower CBD in the current forms of cannabis is that you have a form of cannabis that has more THC, which is the primary psychoactive constituent of cannabis, and less CBD, which may protect against some of the effects of THC. In addition to the fact that the potency of cannabis has changed over the last few decades, we now have a staggering array of different products that have a THC content of up to 90%. So again, just as a reminder, the average THC content of cannabis in the 1990s and before was about 4%. And there are some forms now of cannabis or cannabis derivatives that have up to 90% THC. So that's more than 20 times more than the average THC content of cannabis back in the 60s. And if we believe that the good and bad consequences of cannabis are related to its THC content, it will be important then to understand why having such high potency products might be problematic. So I'm going to briefly talk about the endocannabinoid system. So we really didn't know how cannabis worked until about 1963, when Rafi McCullum, an Israeli scientist, discovered that THC was the principal active constituent of cannabis. So that was in 1963. But despite knowing what the principal active constituent of cannabis was in 1963, we really didn't know exactly how cannabis or THC produced its effects until the late 1980s. So back in the 1980s, around 1988, a scientist working at the National Institute of Mental Health discovered, and this is a slice of the rat brain. If you can see my cursor, this section of the brain is the cerebellum, and this is the forebrain. And the areas that are lit up, that appear like fire hot, are areas that have a high density of cannabinoid receptors. So the cannabinoid receptors were discovered in the late 1980s. We now know that there are at least 2 cannabinoid receptors. One, the CB1 receptor, is present mainly in the brain and is responsible for modulating most of the psychoactive effects of THC and cannabis. There's also a second receptor called the CB2 receptor, which is present mainly in the periphery. It's still present in the brain at very small amounts, but it's mainly present in the periphery, and it's mainly present on white blood cells and other organs, other immune organs across the body. In addition to these CB1 and CB2 receptors, some of the effects of THC are also modulated by 2 other kinds of receptors. One is the TRPV1 and the TRPA1 receptor, and a receptor that's yet to be named called an orphan G protein coupled receptor. So now we know how cannabis and THC produces its effects via these receptors. We now know a lot about where these receptors are. In the brain, for example, the panel on the left-hand side, cannabinoid receptors or CB1 receptors are present in those areas of the brain that match up with the known effects of cannabis, as in sections of the reward system in the basal ganglia that make a person feel high, a high density of these receptors in the hippocampus, which processes memory, and that's why cannabis and THC have memory impairing effects. High density in the cerebellum. The cerebellum is really important for psychomotor function and coordination. And then, as I mentioned, they are also present, the CV2 receptors are present on white blood cells. They're present in reproductive organs, in many sections of the immune system, and so on and so forth. We are fortunate now to be able to actually look at the distribution of cannabinoid receptors in the living brain. This is data from my lab. We are using a technique called positron emission tomography. The upper panel are the MRIs of subjects, of healthy controls, and the bottom panel shows the density of cannabinoid receptors. And these red areas are areas that have high densities of cannabinoid receptors. These are different sections of the brain. And what this allows us to do is it allows us to look at the density of cannabinoid receptors in the living brain. And I'll come back to this approach later on in the talk. So once the cannabinoid receptors were discovered in the 1980s, the next logical question that scientists asked were, well, why does the human body have cannabinoid receptors? And what is the natural substance that might bind to these cannabinoid receptors? As you probably know, just as morphine comes from the opium plant, the body makes its own morphine-like substance that we call endorphins. And likewise, we now know that the brain and the body produces its own cannabis-like substances. The two substances, the two main endocannabinoids are called anandamide and 2-AG. Anand is the Sanskrit word meaning bliss. And so this is the principal, one of the principal endocannabinoids, and the other one is 2-arachidonyl glycerol, or 2-AG for short. So we now know that the brain produces its own cannabinoid-like substances. It's not just the human brain. Cannabinoid receptors and the endocannabinoid system are found in animals, and it has nothing to do with whether someone uses cannabis or not. This is present in the brain. And so one of the next logical questions is, why do we have a cannabinoid system in the brain? What is its function? So we now know a lot about the endocannabinoid system. This is a very busy slide, which I'm not going to spend too much time talking about, other than to make the point that we now know where these cannabinoid receptors are located in the synapses. We know how anandamide and 2-AG are synthesized, how they are destroyed. We know what the enzymes that are involved in synthesizing these endocannabinoids. And why that's important is it offers an opportunity for us to develop drugs that might work on the endocannabinoid system. But that's for another talk. So with that background in mind, I'm going to talk a bit about the exocannabinoid system, or the exocannabinoid hypothesis. But before that, I wanted to make some really important points. The first is that the idea that cannabis or cannabinoids are associated with psychotic disorders or psychotic phenomena is not something new. This is a treatise that was written by a French physician, Moreau. This was back in 1845, so almost 100 years ago. Much more than 100 years ago, almost 200 years ago. And this is translated from French. And he wrote, psychotic reactions lasting but a few hours, but occasionally as long as a week. The reactions seemed dose-related and included paranoid ideas, illusions, hallucinations, delusions, depersonalization, confusion, restlessness, and excitement. Now, even though at that time the concept of schizophrenia had not yet been coined, I'm sure most of you would agree that these symptoms, if we spoke about them in today's day and age, most of us would agree that these are some of the classic symptoms that we associate with psychotic disorders or schizophrenia. I'm originally from India, and as you know, the British colonized India for a number of centuries. And this is these are writings from the first European psychiatric hospital in India, one of the oldest psychiatric hospitals in Southeast Asia. And the then director of the hospital wrote, and I've highlighted here, about Indian hemp insanity. And what he described here was that at larger doses, I'm here using cannabis, there occur excitement, delusions, hallucinations, activity with a tendency for violence, ecstasy, and deep sleep, followed by forgetfulness of all but the initial symptoms. So some of these resemble, obviously, the symptoms of psychosis. And he further went on to describe this hemp insanity as acute mania, chronic mania, and dementia. So just to make the point that the recognition that there's a relationship between cannabis use and serious mental illness like psychotic disorders was something that was recognized more than 200 years ago. So I would argue that there are essentially three distinct relationships between cannabis or cannabinoids and psychosis. And just moving forward in the talk, I'll interchangeably use the word cannabis and cannabinoids, and you'll understand later why. I would use these terms interchangeably. So before I get to these three relationships, I wanted to make a couple of really important points. And one is that one might think about psychotic symptoms as I described in the two descriptions earlier. Psychotic symptoms, which include perceptual alterations such as hallucinations and illusions, delusions, paranoia, ideas of reference, disorganized speech and behavior. We think of these as psychotic symptoms, and these constitute a psychotic disorder. So that is my roundabout way of saying that psychotic symptoms are just part of the many other symptom domains present with a psychotic disorder. And the other main symptom domains in psychotic disorders include negative symptoms, cognitive deficits, and of course, all those translating into functional deficits, and sometimes mood symptoms. So keep this distinction in mind: psychotic symptoms and a psychotic disorder. Now, the other concept that I'd like you to keep in mind is that we often talk about schizophrenia, or the prototypical psychotic disorder, as if it's one syndrome. But I think it's becoming more and more clear to us that actually schizophrenia may be a kind of lump term that lumps together many, many different kinds of psychotic disorders under one umbrella term of schizophrenia. And it's conceivable that in the next 20 or 50 years, we might discover that this umbrella term schizophrenia may actually consist of many distinct psychotic disorders that may have a different etiology and may have different treatments. One such potential subtype might be one that's related to substances, and more specifically, one that might be related to cannabis. And I'll talk about that later on. So with that preface in mind, what are the three relationships between cannabinoids and psychosis? This is just my way of kind of organizing the information into a way that might make sense. So the three relationships are, the first being exposure to cannabis or cannabinoids followed immediately by intoxication, and where psychotic symptoms just occur around the period of intoxication. That is, they do not last for very long. So I would refer to this as an acute transient psychosis. The second relationship that I would describe would be where the psychosis or the psychotic symptoms begin soon after exposure, but in this case, they last for much longer than the period of intoxication. For those of you who know, the intoxicating effects of cannabis last maybe half an hour to an hour at the most. So the second relationship is the idea where psychosis begins shortly after exposure, but lasts for up to days and sometimes up to weeks. And finally, the third relationship is that of exposure to cannabis in adolescence, followed months to sometimes years by a chronic recurrent psychosis that we currently in our current terminology called schizophrenia. So these are the three relationships that are based on the temporal relationship and how long the effects last. So I'm going to present to you evidence supporting each of these three relationships. The first being acute transient psychosis. So what is the evidence to support the idea that cannabinoids can cause acute psychotic states that last for half an hour to an hour? So there's observational data, there are anecdotal reports, there are case series published in the literature um, of people developing acute psychotic symptoms in the context of using cannabis or cannabinoids. Um, there are, in surveys of cannabis users, about 20% of cannabis users will tell you that at some point in the past, they may have felt paranoid or may have felt their name being called out, and other quasi-psychotic-like symptoms. Now, if you look at the package insert for some of the medicinal cannabinoids present, such as dronabinol, which we use for chemotherapy-induced nausea and vomiting, if you look at the package insert, they describe that some people cannot tolerate these products because they will report or they'll experience paranoia and even frank hallucinations. And finally, synthetic cannabinoids, which I'll hopefully come to later on in the talk. So THC is the classic phytocannabinoid, as in it's derived from plants. But we now know that there are a number of synthetic cannabinoids also present, which were for some time sold under the name Spice and K2. And I'll talk about that later on. And these synthetic cannabinoids have been also associated with acute transient psychotic phenomena that last for maybe sometimes hours, but in some instances, even up to days and weeks. And finally, experimental data. So the reason I wanted to spend some time talking about experimental data is that there are always problems with, there's some limitations with observational data. What do I mean by that? So if someone develops psychosis after using cannabis, it's possible that they may have developed the psychosis because they had a genetic predisposition for psychosis, and that was the reason they developed psychotic symptoms. This is where experimental studies can allow us to really address the literature, the limitations of observational studies. So just going back to medicinal cannabinoids, the ones that are currently available on the market, commercially available in the US, are dronabinol, which is synthetic THC, and nabilone, which is a THC analog. And many years ago, the company Pfizer had developed a drug called levonorgestrel, which was very good at treating pain. Unfortunately, it was associated with many side effects, and many of the side effects had to do with psychotic-like symptoms. And so it never really came on the market. But these are some of the observations or what's noted in the package insert for dronabinol and nabilone. Thought disturbance, feelings of unreality, fear and paranoia, hallucinations, difficulty concentrating. These are all symptoms that we would otherwise call psychotic symptoms. Now, experimental studies afford us some advantages over observational studies. First, you can deliver a drug in a standardized way. As you know, when people smoke a joint, they can take one hit, they can take 5 hits, they can hold their breath for 1 minute or just 20 seconds. And so there's a lot of variability in delivery. We can look at many different doses. We can look at a dose response. We can do within subject studies where we compare subject under placebo, the same person under placebo, and then under THC. We can exclude the effects of other drugs that might contribute to psychosis. And because of the clear relationship between how a person was before they got the drug and after the drug, it can allow us to make statements about causality with much greater confidence. I've spent a good part of the last 25 years doing studies with intravenous THC in many different groups of subjects, and I'm going to present to you some of that experimental data, which, as I mentioned earlier, addresses many of the limitations of the observational data. So in the first study that we did, we invited healthy individuals who were very, very carefully screened for any psychiatric disorders. So these were psychiatrically and medically healthy individuals, and they took part in a 3-test day study. And on each test, across these 3 test days, they received placebo, a low dose, and a medium dose of THC in random order under double-blind conditions. So I did not know what they were getting, and they did not know what they're getting. And we looked at a number of outcome measures, including measures of psychosis, etc. So what did we find? In this study that was published now almost 20 years ago, we found that, and let me orient you here, placebo is always in blue, low dose of THC is in green, and the medium dose of THC is in red. The y-axis here is the positive and negative syndrome scale, which is a classic scale used to measure symptoms of schizophrenia. And this is the positive symptom subscale. So this refers to symptoms such as hallucinations, delusions, paranoia, and thought disorganization. The x-axis is time. So what we find here is on the placebo condition in blue, there's no change in PANSS scores, a positive symptom. But with each dose of THC, the low and the medium dose, there is a transient increase in symptoms measured using the positive and negative syndrome scale. Well, you might ask, what kind of symptoms do people report? Healthy individuals who are carefully screened for any risk of psychosis or psychiatric disorder. What kind of symptoms did they report? And I have a smattering of some of their observations. I couldn't keep track of my thoughts. It suddenly disappeared. It seemed as if everything was happening to me at once. Everything was happening in staccato. My thoughts were fragmented. The past, present, and future all seemed to be happening at once. We refer to this as conceptual disorganization. Some subjects had really unusual thoughts. I thought you could read my mind. That's why I didn't answer any of the questions. I felt as if my mind was nude, that you knew exactly what I was thinking. I felt I could see into the future. I thought I was God. And then, of course, paranoia, which if you know anyone who uses marijuana, it's fairly common knowledge that some people who smoke marijuana will feel paranoid that people are watching them, or the police are around the corner, or they're going to get into trouble with the authorities. But for example, some of the subjects in our study reported, I thought you were trying to trick me by changing the rules of the tests. I thought you were turning the clock back to confuse me. I thought this was real. It wasn't an experiment. And one of the subjects lost complete insight. He thought that we were continuing to give him THC through the blood pressure machine and the sheets. So some subjects obviously had some of these symptoms, and not all subjects have. And so before I continue any further, I should make an really important statement here. Most people who use cannabis sporadically, and most people who use cannabis do not have negative consequences. So just to, I don't want to sound like a scaremonger, but the point here is that most people who use cannabis do not have negative consequences. And that's because most people who use it in very small doses and use it sporadically. Okay, so these are positive symptoms. What else did we find? We also found that subjects had negative symptoms and also had cognitive deficits. So if you may recall earlier when I was setting up these slides, I made the distinction between positive symptoms that are just part of the overall syndrome of schizophrenia. Cognitive deficits are another major component, domain of schizophrenia. And the most common cognitive deficit that we see in psychotic disorders are deficits in memory, which are usually measured using a verbal memory scale. And let me quickly walk you through this. So this is a scale where we read a list of 12 words to the subject, and we read it 3 times. And the idea is that with each repetition, a person will recall the list, so that by the 3rd repetition, they've almost recalled all 12 words. So this is the placebo condition. And you can see that on the 2 THC conditions, this really impairs a person's capacity to learn and recall verbal information. You might imagine then that this would have significant implications on someone who's a student. So if you're in school and you need to learn new information, and you're under the influence of THC or cannabis, it would make it really hard for you to learn and recall that information. So that same 12-word list after about a 30-minute delay, we ask subjects to recall the same list. And you can see on the placebo condition, subjects are able to recall 10 words, and with some recognition cues, they can recall almost all 12 words. And THC at the 2 doses seems to impair delayed recall. Okay, so one of the important perceptual alterations in schizophrenia and psychotic disorders that we don't really think about enough is some deficits in time perception. So patients with schizophrenia are notoriously inaccurate in being able to assess time across the seconds and minutes domain. And you can imagine our capacity to accurately assess time has enormous implications. And if that is really impaired, you could imagine how that might affect many of the other things that we do. Now, we know from anecdotal evidence that when people are under the influence of THC, they describe that time seems to pass very slowly. What we did in the series of studies, is we looked at that in a much more systematic way in an experimental study where we used a placebo control, and shown here, let me just go back to, shown here is placebo in yellow and the different doses of THC with different colors. We had 2 kinds of tasks, a time estimation task and a time production task. And time estimation task went something like this. The subject would hear a beep, and then say after 5 seconds, they hear another beep, and we'll ask them to determine how much time had elapsed. And you can see here that under the influence of THC, time estimation is significantly impaired, so that under the medium dose of THC, people are off by about 30%. That would be another way of putting that would be, let's say there was a 10-second interval that I gave people. They would estimate that as 13 seconds or as 7 seconds. They'd be off by about 30%. So again, both on time estimation and time production tasks, we see robust effects of THC on these measures of time estimation and time production. So now moving on to measures that actually look at brain function. This is data from an EEG task. So here we are measuring brain wave potentials. And in this task, it's a very simple task. It's an attention task where subjects will hear tones in on headphones, and that would go something like beep, 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 boop. And every time they hear a different stimulus, a boop, they have to hit the space bar. So what we are trying to measure is whether someone is able to attend and recognize something new from a series of standard tones. What happens is when people recognize that novel stimulus, it generates a waveform 300 milliseconds after the stimulus. And therefore it's called the P300 task. Shown here, placebo is in blue, and the 2 different doses of THC are in green and red. So now this is a response that is actually looking at brain activity, and it doesn't depend on someone being particularly cooperative. So what we find here is that THC reduces amplitude on this P300 task. And we think that our interpretation of that is that THC is disrupting the allocation of attention and the updating of context. Okay, so I'm not going to tell you all the data that we've collected with these experimental studies, other than to say that there is some overlap. There is some overlap between some of the acute effects of THC, seen in observational studies and in experimental studies, and some of the symptoms that we observe in psychotic disorders. And that includes positive symptoms, which I discussed earlier, other perceptual alterations I did not mention earlier, but negative symptoms too, verbal memory deficits, spatial working memory deficits, executive function deficits, attentional deficits, P300 deficits, which I just showed you on the EEG task, and a couple of other measures of brain activity, including gamma oscillations and cortical noise. So at least the other important point to keep in mind is obviously there's not perfect overlap between the acute effects of THC and psychosis. But the point here is that THC can induce some of the symptoms that resemble some of the symptoms that we see in psychotic disorders. I'm a clinician, and most of the patients that I treat are patients with schizophrenia. And when I came here to Yale back in 1992 as a fellow, I was struck by one of my patients who kept saying to me that every time he smoked cannabis, his voices got better. And I would see the same patient down in the ER several hours later. And so there was this mismatch between what the patient was telling me and what I was observing as a clinician. And when I looked at the literature to inform me, all I could find was this notion of a self-medication hypothesis. At least at the time back in the early 90s, the idea was that patients with schizophrenia were using cannabis to self-medicate some of the core symptoms of schizophrenia. Just as my patient said, as in he said he was using cannabis because it made his hallucinations better. But when I looked more closely at the literature, it didn't look like there was any data to support it. It was really common sense based, but there was no data to really support that. And the reason I say that is we know that with substance use disorders, denial and rationalization play really important roles. If you talk to someone with an alcohol use disorder, I'm sure they will give you very good reasons why they use alcohol. That it makes anxiety less, it makes them feel in better control of stress. So people can give you good reasons, but we know that those are often rationalizations. Second, we know, as I've shown you from experimental studies, that if you ask someone about something that happened many hours or weeks ago, as in you ask someone, when you smoke cannabis, and that could have been days ago, what does it do for you? You're relying on someone's accurate recall of what happened. And as I've shown you, THC disrupts memory. And so relying on self-report may not be the most accurate way to do it. So I decided then that I would actually do an experimental study to see for myself in real time what cannabis was doing to people with schizophrenia. And so we did the study. Similar to the studies that I just spoke to you about, experimental double-blind placebo-controlled studies where we invited patients with schizophrenia who were chronic and stable and on antipsychotic medication and who had used cannabis. We invited them to take part in a 3-test study where they received placebo, low dose and medium dose of THC in random order. And what did we find? We found that THC increased positive symptoms of schizophrenia in these chronic, stable patients who were taking antipsychotic medications. So shown here in blue is the placebo condition. There was no change in symptoms. Shown here in green and red are the 2 doses of THC. And you see that it increased positive symptoms such as hallucinations, delusions, paranoia, and so on and so forth. Also important for you to remember is that by the end of the test day, which is 200 minutes later, or about 3.5 hours later, the subjects were back to their usual level of symptoms. In addition to positive symptoms, THC also increased negative symptoms, whereas placebo condition did not. Now, what was interesting is that THC induced or increased or exacerbated those symptoms that were unique to the individual patient. So that is another way of saying that THC did not induce new symptoms, new psychotic symptoms that the person had never experienced before. Rather, THC exacerbated those symptoms that were unique to that individual patient. Furthermore, just going back to that verbal learning task that I discussed earlier, where people are to recall 12 words, shown here are healthy subjects. On the placebo condition, they recall almost 10 words, and with the 2 doses of THC, they do worse. Shown on the right are patients with schizophrenia. The first thing you realize is that on the placebo condition, consistent with what we know about schizophrenia, patients with schizophrenia perform worse than healthy controls on these verbal learning tasks. But under the influence of THC, they do really disastrously. That is, out of 12 words, on the medium dose condition, they are only able to recall 2 words out of 12. So what we found in this study was that patients with schizophrenia were much more vulnerable to the memory impairing effects of THC than healthy controls. Furthermore, going back to the positive symptoms, we found that patients with schizophrenia were also more vulnerable to the positive symptom inducing effects of THC relative to controls. So in our hands, at least, we find no evidence to support the self-medication hypothesis with THC. I think in my clinical practice, I've stopped using this term self-medication because in some ways it colludes with patients, and because it really is not founded on any scientific basis. In addition to my study, a colleague of mine in the Netherlands did a much more ecologically valid study. In her study, Cecile Henkitz published this study back in the mid-2000s. She gave patients beepers, and the beepers went off maybe 5 times a day at random times. And patients were to record at the time the beep went off how they were feeling in terms of how their psychotic symptoms were, their hallucinations, etc., and whether they had used cannabis between that beep and the previous beep. And so what that allowed them to do in this ecologically valid way is to find out the relationship between a person's symptoms, individual symptoms of psychosis, and their use of cannabis. And the self-medication hypothesis would have suggested that when a person's symptoms were up, that's when they would use cannabis, and their symptoms after using cannabis would go down as evidence to support the self-medication hypothesis. What Cecile found was the opposite, which is that symptoms, basically psychotic symptoms, got worse after patients used cannabis in this ecologically valid study. So what is likely happening is the following, that patients with schizophrenia are using cannabis for the same reasons everyone else uses cannabis: to chill out, to disconnect from what's around them for the moment. But what happens with patients with schizophrenia is that chilling out or that anxiolytic effect may last for 15 to 20 minutes. And then after that, their core symptoms get worse, and they do not anticipate that. So it looks like in some ways everyone is right, that clinicians are right in observing that patients who use cannabis get worse, and patients are right that at least for 15 to 20 minutes, they may be experiencing some disconnect from the symptoms that trouble them. Okay, what about patients who don't have established schizophrenia? These are clinically high-risk individuals. And clinically high-risk individuals are those kinds of individuals who maybe have a family member with schizophrenia, or have reported attenuated psychotic symptoms to their pediatricians or the school. This is work not done in my lab, but done at Columbia University. And in this study, they had healthy controls and patients with who were clinically high risk for schizophrenia smoke cannabis using a vaporizer. And they looked at a number of outcomes. They looked at paranoia, anxiety, and high. As you can see with the healthy controls shown here, there was no change in paranoia, a small change in anxiety, and consistent with why people use cannabis, a report of high. So what happened with the CHR individuals? In contrast to the healthy controls, the clinically high-risk individuals reported an increase in paranoia, reported an increase in anxiety, and were no different from the healthy controls in terms of high. So the take-home message from this is that people who are clinically high risk for schizophrenia might be more vulnerable to the psychosis like inducing effects of cannabis than healthy controls, even though they have not yet developed full-on illness or the syndrome. And the take-home message from this is, I tell my younger patients, if they have siblings, to have their siblings refrain from using cannabis until they're in their 20s. At least that's the message I give them. Whether that actually happens or not is a different matter. Okay. Now, what about family members of people with schizophrenia? My colleague Mohini Ranganathan invited people who have a family member with schizophrenia, but who are not diagnosed themselves, to participate in an experimental study where they received THC or placebo in a double-blind randomized study. And what she found here is that those with a family history of schizophrenia who are not ill themselves, shown here in red, compared to age and gender match controls, shown here in blue, the ones with a family history of psychosis had an increase, had greater increases in positive symptoms of psychosis and overall symptoms of psychosis relative to those without a family history and relative to the placebo condition. So again, this is not, while this is not published data, this is other convincing data suggesting that people with a family history or who are at high risk for schizophrenia may be more vulnerable to the effects of THC. So moving on now to the second relationship, that of acute psychosis that begins shortly after exposure, but in this instance, it lasts for several days or sometimes even up to weeks. So it manifests immediately following exposure, lasts well beyond the period of intoxication, sometimes resolves within days to weeks. It seems to recur with future cannabis use. It seems to require clinical intervention. And the last point I'll come to in a minute. So I want to turn your attention now to, I've spoken a lot about phytocannabinoids or the cannabinoids that are derived from the plant cannabis. But we now know there are also a number of synthetic cannabinoids. So a chemist at Clemson University, John W. Huffman, whose initials are JWH, he and his lab, and he had a number of talented postdocs, in an effort to understand the brain cannabinoid system and the endocannabinoid system in general, synthesized a bunch of synthetic cannabinoids and published these in medicinal chemistry journals. Someone took the recipes from these journals that were really for science and just followed the recipes and came up with and were able to synthesize these products. They then began to sell these products under the guise of potpourri. So they took herbal potpourri, sprayed them with these synthetic cannabinoids and sold them starting in Europe in around 2008 and ending up in the US shortly thereafter. And what we began to see both in Europe and here is new cases of people who gave the following history. They went to a party, they smoked something that they didn't know what it was, and then ended up in the ER with a full-on psychotic break. It also became popular amongst people who did not want to, who wanted to avoid being detected, as in people who were on probation and who had their urine tested by their probation officers, people who were in the military service, because the standard urine tests do not, which only measure the metabolite of THC, cannot measure these substances. So initially, the first drug that came here to the US was JWH 018 or John W. Huffman 018. And as soon as the DEA recognized that this was a product in these substances being sold under the name Spice and K2, they banned these drugs. And then what the suppliers decided to do is they just went to the next drug. They made JWH 019 and so on and so forth until it became really a cat and mouse game. The good news is that the DEA has banned all the drugs belonging to this class. But what's really important to understand about these drugs is in my next slide. So this is a busy slide, and those of you who are not scientists, I don't expect that you will understand this, but let me try and walk you through this. This column shows how much and how potent a drug is at the cannabinoid receptor. And what's really important, and it's counterintuitive, is the higher the number, the less potent and the less that drug likes that receptor. So here is delta-9 THC or THC, which is the principal phytocannabinoid in cannabis. And its affinity and potency of the cannabinoid receptors is 41. All these other drugs, starting with JWH 018 going down, the numbers are much lower than 41, meaning to say that all these drugs like the cannabinoid receptor much more than THC. That's number one. Second, much more important, is these drugs listed here are between 10 and 200 times more potent than THC. So now you might understand why we began to see these catastrophic reactions that some people were experiencing after they used some of these synthetic cannabinoids. The way the suppliers got out of the legal implications is when they sold these products, they sold them as potpourri, and listed at the back was, if you used it, it was at your own risk. And so people used it and had these bad reactions, and they couldn't really hold these companies liable. Anyway, the use of these synthetic cannabinoids have also provided us another line of evidence suggesting a relationship between cannabinoids and psychosis. So we had data on phytocannabinoids or plant-derived cannabinoids. Now we have data on synthetic cannabinoids in addition. So I want to draw your attention to a very interesting set of studies that I'm going to point out to you from Denmark. This is work that was published in 2020 on cannabis-induced psychosis. So DSM-5 and ICD-10 recognize cannabis-induced psychosis, which is basically psychosis that begins in the context of cannabis use and is usually short-lived, but usually requires some kind of clinical intervention. So one of the reasons we often end up looking at data from Scandinavian countries is because, unlike our country, most of the Scandinavian countries have a national healthcare system, a very good one that too. And they keep excellent registries that allows them to look at data across the entire population. So this kind of a study would be impossible to do in the US. But anyhow, what they found was that between 2006 and 2015, there has been a threefold increase in cannabis-induced psychosis in Denmark. As you know, Denmark has a nationalized healthcare system. So everyone who is hospitalized, that information is recorded and registered. And so it's easy for researchers to look at. So what is really important here is that this threefold increase in the rates of cannabis-induced psychosis was paralleled with an increase in the potency and availability of cannabis in Denmark. So the THC content of cannabis in Denmark went up around the same time, and the availability also of cannabis went up, providing some compelling data associating the increase in cannabis-induced psychosis with the increase in the availability and potency of cannabis. Okay. They also looked at the rates of people who already had schizophrenia who developed cannabis use disorder. So these are duly diagnosed people. And they found that while there was a slight increase in those who were duly diagnosed with schizophrenia and cannabis use disorder, there was a much greater increase in cannabis-induced psychosis. Now, what about conversion? Many substances have been reported to cause psychosis. And many of those substance-induced psychotic disorders can sometimes convert into schizophrenia. So this slide, the main point I want to leave you here with is that the rates of conversion to a chronic psychotic disorder like schizophrenia is highest for cannabis compared to all other substances that are known to cause substance-induced psychosis. This is really important information that in, again, longitudinal studies done in Finland, they found that those individuals who were diagnosed with a cannabis-induced psychosis, if you followed them for the next 10 years, between 50 and 70% of them were re-diagnosed in the next 10 years with a schizophrenia spectrum disorder, suggesting that if you have an event of cannabis-induced psychosis, that may be a harbinger of something much worse to come, as in a chronic recurrent psychotic disorder. Okay, going on to the last third relationship between cannabis and later recurrent psychotic disorder. There have been a number of epidemiological studies done from starting with Sweden, but now done in many, many different countries, showing that if you have been exposed to cannabis in adolescence, your risk for schizophrenia will increase by anywhere between 2 and 4-fold. So this is a busy slide, but the point here is that studies were done in Sweden, Germany, UK, US, all over the world, large numbers of subjects. And if you look at the overall estimates, your odds for developing a psychotic disorder, if you've been exposed to cannabis in adolescence, is between 2 and 4-fold higher. I want to point your attention to a much more recent study, a multinational study involving 8 countries, including Brazil and Europe, where they looked at the relationship between the frequency of cannabis use, the potency of cannabis, and psychosis outcomes. And what they found in this study is that there was an increased risk of psychosis with increasing frequency, as in daily use, and higher potency. In Europe, high potency cannabis is called skunk cannabis because it has a really pungent aroma. And if you used cannabis daily and you use high potency cannabis, shown here, your risk of developing a psychotic disorder was actually almost 6-fold higher than if you never used cannabis or if you never used cannabis. So this is data published in Lancet Psychiatry from 2 years ago. Okay, I want to introduce another concept called the population attributable risk factor fraction. What this basically means is, can we develop an estimate of the proportion of cases of schizophrenia that would not have occurred, or rather would have been prevented, if no individuals had used cannabis? And I point you to a study that was published just earlier this year in the prestigious JAMA Psychiatry, showing that the population attributable risk fraction, has increased from 4 to 8%. So it has doubled between 1992 and 2016. This is also in parallel with the increasing availability and potency of cannabis in Denmark. Okay, so we now know that the frequency and amount of cannabis a person is exposed to, it's the potency of cannabis, the duration of exposure, the earlier the exposure, are all confer a greater risk in the development of for later psychotic disorder. But, and really this is important for everyone to keep in mind, not everyone who uses cannabis develops psychosis, and not everyone with a psychotic disorder has been exposed to cannabis. That means that cannabis is neither necessary nor sufficient, that it's more likely a component cause. One analogy I can give you is that not everyone who smokes cigarettes develops lung cancer, and not everyone who has developed lung cancer has been exposed to smoking. So, but yet we know that smoking is an important contributor to the development of lung cancer. So it's a component cause that interacts with many other factors that we don't fully understand. So in the same way, cannabis is a component cause that it interacts with other factors, such as genetic factors and other environmental factors like childhood trauma, etc., that, and in doing so confers a higher risk for a psychotic disorder. So I'm going to move on to, I think I have about 15 minutes left. So one of the challenges to studying the long-term effects of cannabis is that it's unlikely that we will ever be able to do experimental studies, unlike some of the experimental studies that I showed you. And by experimental studies, what I'm saying is it's not going to be possible for us to take a group of kids and randomize them to receive cannabis and another group to receive placebo and see what happens to them. That would be unethical. That would be impossible to do. So no point even going there. But there may be other alternatives. But before that, I wanted to talk about some of the limitations of the epidemiological literature. Most of the epidemiological literature, or the data that I showed you about the risk for schizophrenia, focuses mainly on positive symptoms, because positive symptoms are easy to recognize. None of the studies, to my knowledge, really look carefully at cognition or negative symptoms. And while there's some data to suggest that there was a dose-response relationship, most of those studies included people who used very limited amounts of cannabis. That is to say, could it be possible that there are people who use cannabis really heavily, and by studying them, would that allow us to look at this relationship between cannabis and psychosis more carefully? Also, as I mentioned to you, the earlier the exposure to cannabis, the greater the likelihood of bad outcomes. And so many of these studies did not really include people who had been exposed to cannabis very early. And finally, most of these studies relied on self-report, as in there was no no way to test whether people had been exposed to cannabis and how much they had been exposed to. So I'd been thinking about how to answer this question, and I stumbled upon a group that allows us to study the exposure to very heavy cannabis use. This group, for them, their interpretation of the Bible is the herb that's referred to in Psalms 104:14 is cannabis. So for those of you who don't know, the psalm, it said, "He causeth the grass to grow for the cattle and herb for the service of man." The herb referred to here is cannabis, and they believe cannabis is a sacrament, so it's sanctioned by the group. And furthermore, they are forbidden from using alcohol, nicotine, and other drugs. So this allows us to isolate any consequences to just cannabis and nothing else. Again, they refer to the Bible: "He shall separate himself from wine and strong drink." And that's the reason they don't use alcohol and nicotine. Their exposure to cannabis is massive. It's more than 25,000 times in their lifetime. Exposure is often in utero because the women continue to use cannabis during pregnancy, and there's no problems related to procurement or possession. So what we found I will refer to them as cases and controls. On the y-axis, we measured, what we were measuring was schizotypy, or ideas such as magical thinking or quasi-psychotic symptoms. And we find that in these cases, they had statistically higher scores on this measurement of schizotypy than controls who were from the same background, the same religious background, with the exception that they did not believe that cannabis was a sacrament, and they did not use cannabis the way the cases used. Furthermore, we did a battery of cognitive tests looking at attention, memory, executive function, and so on and so forth. As you know, cognitive symptoms are a significant problem in schizophrenia and psychotic disorders. And again, what we find here is the cases shown here in red performed worse than the controls on this composite assessment of attention, memory, and executive function. They went in different directions, so to speak. Now, it turned out some of these cases had siblings who did not join their church. So that is to say, they were born, they had the same, mostly same genes, they were raised in the same family, they ate the same food, they had the same upbringing, but they did not join the group and they did not use cannabis. So what that allowed us to look at was to separate genetics from the effects of cannabis. And what we found here, at least on the cognitive testing, is that the siblings of these cases, their cognitive test performance fell somewhere between the cases and the controls. And so that gives us some confidence in being able to say that the deficits that we saw in the cases might be driven primarily by exposure to cannabis. Okay, so obviously, if cannabis exposure results in a chronic recurrent psychotic disorder, we have to ask the question, how might that be? And we now know that that schizophrenia is a neurodevelopmental illness, or many illnesses under one umbrella. And we know that there are two main phases of neurodevelopment. One is in utero, and the other is in adolescence. And we've unfortunately seen in the last 10 years or so in this country, an increasing number of pregnant women using cannabis, and they use cannabis for a number of reasons. One is for morning sickness, to help with the vomiting and nausea, and the other is to treat stress related to pregnancy. And so what this does is it exposes the developing fetus and the developing brain to cannabis, and that might have long-term consequences. So I refer you to a study that's published recently in JAMA Psychiatry, and they looked at children who were born to women who used cannabis during pregnancy. And there were two groups of these women who were using cannabis during pregnancy. Those who were aware that they were using it and doing it, and others who were discovered later on. And we find here on this measure of psychotic-like experiences in children that the children who had been born to mothers who were using cannabis, these two groups, seem to have higher scores on psychotic-like experiences that were measured later on in life. Likewise, they had more internalizing problems shown here, more externalizing problems, and that often goes along with psychosis, and more problems with attention. Looking at things in a more granular way, they also had more thought problems, they had more social problems, and their performance on cognitive tests was worse than those who had not been exposed. So this is some emerging data suggesting that exposure to cannabis in utero might be associated, again, I can't say causal, but associated with outcomes that are of relevance to psychotic disorders. Now, what the other phase of brain development is adolescence. And there is some, again, very interesting data published just this year in JAMA Psychiatry, showing what the effects of cannabis use in adolescence is on the developing brain. So this is a summary slide showing that those adolescents who had been exposed to cannabis in adolescence had thinner prefrontal cortices. The prefrontal cortex is really important for many of our higher cognitive processes, decision-making, executing decisions, and things like that. But now we have, for the first time, clear information on brain structural changes associated with cannabis during cannabis exposure during adolescence. Again, they also looked at the relationship between dose and exposure, and I'll try and explain this in the slide. So shown here is the decrease in prefrontal cortex volume on the y-axis, and on the x-axis is the number of exposures. So that is, the more exposures, the more you go down this line. And you can see that there's a relationship between the greater the exposure to cannabis, the greater the reductions in prefrontal cortical volume, both shown on the right dorsolateral prefrontal cortex and the left dorsolateral prefrontal cortex. So this is now fairly compelling data to show that exposure to cannabis during adolescence is associated with reductions in brain volume. And second, the greater the exposure, the greater the reductions. Okay, this is data from my lab, where we have a very sophisticated technique to look at the number of synapses in the hippocampus. The hippocampus is that part of the brain that is critical for memory. It's also an important part of the neural circuitry of schizophrenia. And we find that individuals with cannabis use disorder, shown here in red, have about a 12 to 15% reduction in the number of synapses in the hippocampus compared to age-matched controls. This effect size was fairly large, and it was a highly statistically significant effect. Furthermore, these reductions, the reduction in synaptic density in the hippocampus, was related to their performance on a memory task. I'm going to close with just 3 slides about the endocannabinoid hypothesis. So I've spoken to you so far about the exocannabinoid hypothesis, according to which exposure to either naturally occurring or plant-based cannabinoids and synthetic cannabinoids is associated with psychotic outcomes. But we're now beginning, there's emerging evidence to suggest that perhaps the endocannabinoid system in the brain might be altered in schizophrenia, and it's unrelated to exposure to cannabis. So again, that there may be a fundamental deficit in the endocannabinoid system in the brain that goes beyond exposure to cannabis. So the first evidence to support this was data from a researcher in Germany showing that there were elevations in anandamide levels in the CSF of patients with schizophrenia. Here are patients with schizophrenia, here are healthy controls, and this is the level of CSF anandamide. As you may recall, anandamide is one of the principal endocannabinoids present in the brain. And furthermore, they found that treatment with antipsychotics seemed to normalize these levels of anandamide in patients with schizophrenia. Several decades later, this is data from a post-mortem study looking at slices of the brain and binding of cannabinoid receptors. And you see here in this post-mortem study that healthy controls have higher numbers of cannabinoid receptors than schizophrenia patients, shown here. Again, these are post-mortem studies, and post-mortem studies carry their own sets of problems. So, including the time between when a person died and when their brain was looked at, and so on and so forth. But these were preliminary studies suggesting that there's a reduction in cannabinoid receptors in the brain that's unrelated to whether people were used cannabis or not. As I mentioned to you, we have the technology to look at brain cannabinoid receptors in the living brain. And here we show data from my lab. These are healthy controls shown in the top panel, and these are patients with schizophrenia shown in the bottom panel. These were patients with chronic established schizophrenia who were not using cannabis, who were not cannabis users. And we find that there's about a 15% reduction in cannabinoid receptors in different parts of the brain relevant to, relative to healthy controls. And again, as I mentioned, this is not related to cannabis. This was published in 2016 in Biological Psychiatry. So it seems like there's evidence, emerging evidence of altered endocannabinoid function in schizophrenia. So I'm going to quickly conclude here. I've shown you data that cannabinoids can induce acute transient psychosis. We can say with confidence that there's a causal relationship because these were experimental studies where a person was fine 1 minute, they received THC, and then the next minute they had these symptoms that were psychotic-like symptoms. The effects are dose-dependent. Patients with schizophrenia are more vulnerable to the effects of cannabinoids. And those who are at risk for psychosis, as in those with a family history of psychosis, or those who are considered clinically high risk, seem to be more vulnerable to the effects of cannabinoids. There's mounting evidence that cannabinoids can contribute to the risk of schizophrenia. An episode of cannabis-induced psychosis might herald the development of a chronic recurrent psychotic disorder. The age of exposure, the dose of exposure are really important. But the million-dollar question is why some people are more at risk than others. We don't quite know. And that's something that we need to actively study. And lastly, there is evidence of altered endocannabinoid function in schizophrenia, as I just mentioned to you. So I'm going to stop there and open it up for questions. Thank you for your attention.
Well, Dr. D'Souza, that was fantastic. You know, as a parent of younger adults, your presentation reiterated some of what I've been preaching for a long time about, you know, the pot from your dad's days when he was young and stupid is not the same marijuana or cannabis of today. And the proof is obviously in the pudding with the you know, the higher THC content causing higher likelihood of psychosis, that sort of thing. But my immediate question to ask there is, you know, you mentioned frequency of use, potency of the cannabis,
and longer exposure raises the risk. What about the familial genetic heritability in a family where there's maybe multiple generations of persons with addiction? Does that also increase the psychosis risk?
Yes, absolutely. We know that if you have a family member with a psychotic disorder, you are at greater risk for developing a psychotic disorder yourself. And I won't go into the actual details, but if you have one parent, your risk is X. If you have two parents, your risk is greater. If you have a twin, it's greater and greater. So we know that. We don't have a formula as yet that would allow us to quantify how your family risk for psychotic disorder interacts with cannabis. We don't yet have a formula. So I can't really tell a person, okay, if you have a family member with psychosis and you use cannabis, your risk for psychosis is 60% greater. We're not yet at that point. But that's an important, it's something that we want to look at.
Okay, good. This question comes from Dr. Jim Gillespie. He asked the question, is CBD anti-inflammatory, and after prolonged use, could it become pro-inflammatory?
Yeah, so that's an excellent question. I think there's a lot of interest in not just CBD, but cannabinoids, because they do modulate the inflammatory pathway. The problem is that I don't think we are, I think the data out there are quite mixed. In some models, for example, THC can be shown to be pro-inflammatory. In other models, it can be shown to be anti-inflammatory. And as you say, some of these cannabinoids might have effects in one direction when used acutely, but with chronic use, they may have effects that go in another direction. I don't think I know enough about CBD's anti-inflammatory profile to be able to say with confidence that it becomes pro-inflammatory after use for a while.
Yeah. So one of our participants asked the question to clarify, THC and synthetic cannabinoids can cause psychotic states, but CBD does not.
Say that again, I'm sorry.
THC and synthetic cannabinoids can cause psychotic states, but CBD does not.
So it's like chalk and cheese. So THC and synthetic cannabinoids, they bind to cannabinoid receptors and they activate cannabinoid receptors. CBD, to our knowledge, we don't actually know exactly how it works, even though it's called a cannabinoid and it's called cannabidiol. How it actually produces its effects remain a mystery. There have been a number of mechanisms that have been proposed, but what's really important is that the mechanism by which CBD produces its anti-anxiety effects and maybe antipsychotic effects are very different from mechanisms by which THC or synthetic cannabinoids produce psychosis.
Okay. Kate Sullivan asked, does your work also have implications for psychosis and bipolar disorder, or is that not clear at this time?
So I think the main interest emerged from schizophrenia, from the schizophrenia literature. That said, we now know that there's quite a bit of overlap, both in the genetics and the manifestation of bipolar disorder and schizophrenia. Some have argued that perhaps they are on a continuum. And we do know that cannabis in general is not a good thing for people with true bipolar 1 disorder. It's just that it hasn't been studied with the same degree of scrutiny that schizophrenia has been studied. But I would argue the same concerns that we have with regard to schizophrenia would be concerns that would extrapolate to bipolar disorder.
Okay, good. We actually have two questions on the same subject, which is kind of fascinating. Two folks wanted to ask the question about recurrent seizures being brought on by consistent or daily use of cannabis in persons with schizophrenia.
I haven't heard of seizures related to cannabis. That's a new one for me. And in fact, I would say there is some data supporting the use of cannabidiol for very rare forms of seizures in children. And if you look at the existing literature, there have even been suggestions that THC may have some anticonvulsant-like effects. So the fact that someone had a seizure would make me concerned about two things. One is what was present in that cannabis, because as you know, most of it is unregulated and we really have no way of telling what's really in there. And the second is that does that person have an underlying seizure disorder that may have been unmasked by the use of cannabis?
Right, good. Okay. Is there a difference between Delta 8 and Delta 9?
Yes, in terms of chemical structure there is, but in terms of effects, they both produce the same kinds of effects. And this is where our laws, and the bureaucracy really is kind of hard to understand. Both of them produce their similar effects, but because their structure is different and because Delta 9 is recognized as the principal psychoactive constituent of marijuana, Delta 8 wasn't on the DEA's list, but I suspect it is going to eventually, because as someone pointed out, it's now being sold in especially I think in Texas and other places, it's being sold at gas stations because it's unregulated. It's a matter of time, I think, before it's going to get regulated.
Yeah. Okay. Amanda Lewis asked a question. You made the statement, most people who use cannabis use sporadically and do not experience negative consequences. Do you believe this applies to those who started using cannabis at a young age or adolescence, or does it only apply to adult onset cannabis use?
So I'll tell you what I do know. I think there are several studies that would suggest, and this kind of makes common sense. Think about it this way. The biggest changes in the brain happen during adolescence. It's a time of great upheaval where many connections that were unnecessary are being pruned off and connections that are necessary are being strengthened. Okay. Now we know that the endocannabinoid system, and I didn't touch upon this in my talk, seems to play quite an important role in pruning and neurodevelopmental processes. Okay. Now, what I did not say, I failed to say is that with the endocannabinoid system, endocannabinoids like anandamide and 2-HE are synthesized on demand. They bind to the receptor and they're inactivated within milliseconds. So important point here is that the effects of endocannabinoids are very short-lived, very brief, milliseconds. In contrast, when someone smokes cannabis, THC will bind to the receptor and continue to activate the receptor in a non-physiological manner. Now, just keep in mind, if the endocannabinoid system is important in telling which neurons should be killed and which neurons should be retained, and then it's disturbed by THC, you can imagine how things can go haywire. So exposure to cannabis in adolescence, many studies suggest that it is more problematic. And the earlier that you're exposed to it, the more negative consequences you have. That is not to say that if you're exposed as an adult, you may not have negative consequences. It's just that saying that if you're exposed early on, the consequences are great. When I made the comment about, most people who use cannabis don't have problems from it, I really wanted to make an important point that, often you'll hear from people who are proponents of legalization that the government has fed us with all nonsense about reefer madness and it's all scare tactics, et cetera, et cetera. I'm not here to scare you. I'm here to tell you, provide you the evidence. And the evidence is that millions of people use cannabis and they use it maybe once in a couple of months, and most of them don't have problems from it. But that may have been at a time when cannabis was much weaker than it currently is. And we just need to prepare ourselves that if it's going to get more potent and if it's going to become more available. So the other big game changer in all this, I'm sorry if I'm digressing, but if you'll humor me for a minute, is that we're not really talking about the legalization of marijuana. What we are talking about is the commercialization of marijuana. There's a big difference between that. Human beings have been using alcohol and tobacco for thousands of years. It was the commercialization of tobacco that was the game changer. When there was an industry that developed around tobacco that made cigarettes by the millions, that packaged them in nice packets that you could fit in your pocket, that advertised them with doctors smoking cigarettes and so on and so forth. And we now know that tobacco accounts for the top 5 of global disease burden, and we still have them out there. And the goal of the tobacco companies is to sell as much product. And why should we think that the cannabis industry is not going to do the same? So all I'm saying is that we should be prepared that we might see a similar parallel with what we saw with the tobacco industry.
Right. Another question was on, are there cautions or risks we should be speaking to our patients about regarding Delta 8 versus Delta 9?
Absolutely. I think it's the same. All the information that we have on Delta 9 on our patients should apply to Delta 8. I think you can say that with some degree of confidence.
Okay. And if we test for THC and it's positive and the patient says, oh, they only took CBD, do we assume that they're not exactly telling us the truth?
So a little of both yes and no. So there have been studies that have looked at the labeling of cannabis-based products across the states. And a surprisingly high percentage of the products are mislabeled. So there are products that will say they have 10% THC and they may have 2% THC or may have 20% THC. And likewise, since most of the CBD that is unregulated, most of the CBD market is unregulated, and most of the CBD is derived from the cannabis plant, there are always going to be traces of THC in the product. And so that has the potential of testing positive on a drug test. And this is a big problem. For example, I work at the VA, and at federal facilities, they could do drug testing, and someone may be taking CBD that they bought at Bed Bath & Beyond for a backache, and they would test positive. And if you test positive, you don't have any argument there, because if you test positive for THC, that's a big no-no. So it's conceivable. What I would ask the patient is, what effects they experienced after they consumed the product, because that may give you some kind of indirect assessment of whether the person actually received pharmacological doses of THC or whether it was just a really small, infinitesimally small amount.
Well, Dr. D'Souza, this has been absolutely fascinating for so many of us in this session. We've never had a session like this with, I think we're up to like 15 questions between the Q&A box, and folks have put them in the chat box. So that's telling us that this subject was fantastic and you did a great job. So thank you very much. Last thing I want you to do, though, is tell us what your background is. Is that a building there at Yale, or what is that?
Yes, it is the Sterling Memorial Library at Yale. It's quite a beautiful piece of architecture.
Yeah, it is. It is. There's been folks commenting on it in the chat box. So that's lovely. Listen, thank you again.
Thank you.
You were fantastic. Maybe we can have you in person sometime at the symposium in the future when we don't have to do this virtually.
Sounds good. Thank you.
Great.
Appreciate it.
Thank you so much. Bye.